Good morning, everyone. I am Dr. Ananya and I'll be presenting a case on cancer-associated retinopathy. Introduction. Cancer-associated retinopathy is a rare paraneoplastic disorder of the retina. It is associated with multiple cancers. It can present with sudden progressive loss of vision associated with photosensitivity. Findings in cancer-associated retinopathy include ring scotoma, attenuated retinal arterioles, visual field defects, abnormal electroretinogram, and the presence of circulating serum autoantibodies specific to the retinal antigens. Case, a 63-year-old male presented in IOPD who is a known case of intestinal carcinoma, diagnosed 1 year back with a history of blurring of vision in both eyes since 1 month. Patient was type 2 diabetic since 3 years on regular medication. Patient was chronic alcoholic since 2 years. Patient has received radiotherapy and 6 cycles of chemotherapy for intestinal carcinoma. Complete ocular examination was done. First is the visual acuity. In the right eye was finger counting 1 meters, and in the left eye was 624, and best corrected was 618 on pinhole. Intraocular pressure was normal. Ocular motility was full and normal in both the eyes. Interior segment in both the eyes was normal. Pupil in both the eyes was central, circular, regular, 3 mm in size and reactive to both direct and indirect reflex. There was no associated RAPD. Left eye, there was PCIOL implantation done in the bag operated 3 years back. On fundus examination, as it is shown in the picture, there is bilateral atrophic patches in the retina. FFA showed no active inflammation but a hyperfluorescence around the vessels due to a window defect caused by the RP atrophy. It also shows RP mottling. This is the figure of the FFA. This is the list, which is the total investigations which was done in the patient, including APTT, PTI, D-dimer, HP, RBC, platelet, RFT. The cancer antigen, which was higher, that is 58.89, normal value is less than 37. CE was also raised, the normal value is 0 to 2.9, CECT and CT abdomen. Discussion. Cancer-associated retinopathy leads to rapid progressive visual deterioration with retinal pathology ranging from retinitis pigmentosa to retinal degeneration. After an initial inflammatory phase, late findings include retinal pigment epithelial mottling and retinal atrophy that has been reported and were observed in our patient too. Autoimmunity, which is considered as the main pathophysiological mechanism, causes retinal degeneration in the presence of autoantibodies that cross-react with the tumor tissue and retinal tissue antigens, which are recognized as foreign. It consists of the following antigens, that is carcinoma-associated retinopathy, melanoma-associated retinopathy, paraneoplastic optic neuropathy, and bilateral diffuse uveal melanocytic proliferation. The disease was first described in 1976. The autoimmune reaction itself leads to retinal photoreceptor cell death. No specific test exists to confirm cancer-associated retinopathy, which makes its diagnosis quite difficult. Typically, loss of vision develops over months and can precede the diagnosis of the underlying malignancy. In one study of Adamus et al., only 8 patients of 209 patients had visual symptoms before cancer diagnosis, whereas Rahimi and Saraf reported preceding symptoms in almost half of the patients with cancer-associated retinopathy, but in our case, patients presented with CAR after being diagnosed with cancer. Patient symptoms depends on which retinal tissue is affected, as the CAR can damage to the rods, which can cause nyctalopia, constricted visual fields, prolonged dark adaptation, and mid-peripheral ring scotomas, or it can damage the cones, which can cause photosensitivity, reduced visual acuity, central scotomas, and decreased color perception. Conclusion. CAR or carcinoma-associated retinopathy is paraneoplastic retinopathy which might develop before cancer becomes clinically evident. Patients with paraneoplastic etiology should undergo dilated fundus examination at regular intervals. Diagnostic workup should include screening for anti-retinal antibodies. Thank you.
Thank you. What do you mean by CAR? Cancer-associated retinopathy. What are the features?
Sir, it can present with it depends upon the photoreceptor damage. If more cones are damaged, then it can cause decreased color.
How will it look like on fundus examination?
Sir, there will be bilateral atrophic patches in the region of the macula. If the central region is involved, there will be atrophy in the central region and the periphery.
So how it's different from sometimes you have secondaries in the eye, choroidals, you can see secondaries in choroid, or even in optic nerve can be infiltrated, okay, or how it's different and why, what's the mechanism of this? These
So,
are malignant cells, or they are coming into the uh, layers of retina or uveal tissue, and then they are leading to these changes?
so there is formation of antibodies, which is due to if there is the presence of a tumor, and there is an antigen. There is a
This
presence
is
of
an
the antigen.
autoimmune type of
Yeah, it is an autoimmune
antibody
condition.
reaction.
Cross reaction
So
happens with
it's
the retina.
entirely different from secondaries.
Yes.
So how common CAR is seen?
Sir, it's not common. It's
It's rare.
quite rare.
So you are suggesting that patient who are suspected to have paraneoplastic syndrome, they should be regularly screened
Yeah, and
for
that.
any CAR, evidence of any CAR. So if you see, what you will do?
Sir, first there will be regular dilated fundus examination, and if we can diagnose. So mainly it is topical and systemic steroids, and steroid sparing immunosuppressives can be given, since the main mechanism is raised.
Patient is having some precancerous lesions. So this steroids can't predispose to full-blown remission of these.
So steroid sparing agents, we can also give rituximab, which is a monoclonal antibody. It's recently approved for this.
How would you like to follow up these patients? How will you know whether the condition is improving, stable, or is deteriorating?
We can do serial OCTs also. We can see the photoreceptor area, that is the ellipsoid zone, if we can correlate with the previous OCT images.
Anything better? You said you have already mentioned that it is affecting rods and cones. So how would you like to monitor that?
By visual field, we can
So
see.
visual field will tell you about scotomas, whether scotomas are increasing or not, right? So that is one point. That is how you monitor. How else would you monitor? So the target cells are rods and cones. So which is that? Which is the investigation which are testing your rods and cones?
Electroretinogram, ERG can be done.
So ERG, your fields, and
Oh,
autofluorescence will help you to monitor the
monitor
patients.
patients.